this is Dr. Christian Cox, and for this case we're going to be reviewing thoracic case 018, and in this section it's diffuse lung disease, and this is a really huge topic to try to tackle in one section, but I wanted to introduce you to it and some of the general patterns that we see of consolidation, emphysema, nodularity, and in this case, interstitial lung disease. So this is an older female with increasing shortness of breath, and we have a comparison on the right and the current exam on the left. And one of the first things that I take note of when I'm looking at a chest radiograph is lung volume. This is helpful because if a patient doesn't take an adequate inspiration during the imaging, it can accentuate the bronchovascular markings and make us want to overcall disease that may not be there. But it also can be an indicator that there is actually disease present. Whether that's due to, say, atelectasis from a central obstruction, or in this case, where we've got a lower lung peripheral reticulation in the setting of the decreased lung volumes. So on the prior exam, I want you to take note that as you go out from the vessels, the linear markings that you see begin to disappear by the time you get out into the lateral lung. About the peripheral 1 to 2 centimeters of the lung really show very minimal linearity. There is a small amount in the lung bases and an occasional line here and there. But for the most part, the vascular markings have greatly diminished by the time you get out to the periphery of the lung. In this exam, the more recent exam, I want you to note that as we get out into the periphery of the lung, there's actually an increase in the small linear markings in the peripheral lung. And as you get down to the lung bases, I think you can better appreciate that these linear markings are somewhat chaotic, right? That they don't look like the normal branching pattern of the lung, or even, say, the septa of a secondary pulmonary lobule. Instead, what we're seeing is a bunch of small lines and a loss of the volume of the lung, and as it does that, distortion of the normal architecture. So architectural distortion, volume loss, these fine linear opacities that we describe as reticulation. When I use the word reticulation, I am already implying that there is fibrosis present. So the presence of reticulation is implying fibrosis. So in that setting, in a symptomatic older female, I would recommend a high-resolution chest CT for further evaluation. So the patient gets a follow-up high-resolution chest CT, and in lung window, as we scroll down through this, we're going to see a fine peripheral reticular pattern. So again, notice all these lines out in the periphery of the lung. Notice also that within those areas of fibrosis, we get airways that are distorted and opened, and that's traction bronchiectasis. So we go down further. We can appreciate that there's volume loss, right? So not only are is the interstitium becoming white linearity, but on top of that, the vasculature that is there is getting drawn together. So all these vessels that we do see are brought together by the volume loss. As we get down to the lung bases, we see that there's also peripheral opacities here, but occasionally, well, often, in the supine patient, they can have dependent atelectasis. So just the weight of the lung, incomplete inspiration, can result in increased opacity and decreased volume in the posterior lungs. So what we do to avoid that, or to compensate for that, is we can flip the patient over and obtain prone imaging. And so all that dependent effect goes away for the posterior lung. And the fact that we still have this persistent reticulation and volume loss in the lung bases tells us that this is true fibrosis. And the final set of images that we acquire with this are expiratory images. So some diseases that cause pulmonary fibrosis also cause small airway obstruction, specifically hypersensitivity pneumonitis. So when we get these expiration images, we're looking for air trapping. And on the inspiratory imaging, we'd be looking for mosaic attenuation that would tell us that there's a small airway obstructive component. So take that all together, that there is no real small airway obstruction, that it is a peripheral, fine, basilar predominant pulmonary fibrosis, and that there's very minimal additional findings, such as absence of nodularity, there's no consolidation, there's not much ground glass opacity with this, so really only fibrotic findings. And that combination, even though we don't have honeycombing, which you will often be given examples of, this is still a probable UIP pattern by our imaging criteria, and has a greater than 90% likelihood that if you were to biopsy it, it would be UIP. And in the appropriate clinical setting, this would be consistent with an IPF. That patient, even though they have a UIP pattern, would still need to be worked up for underlying causes such as connective tissue disease. But altogether, this is a UIP pattern, and when there's no evidence of an underlying cause, is consistent with IPF. Thank you very much.